up and hopefully answer as many questions as I can for you today. I've been treating pelvic floor dysfunction since approximately 2007 in private practice. I incorporate it into every diagnosis pretty much that comes through the door, regardless of it is part of our core that's really, really important to our quality of life, as you may know. So I understand that in prior presentations from what I reviewed is that you're very well aware of what stress incontinence is and the causes and why it happens and doing a basic Kegel. There's a lot more that goes into a basic Kegel, and I'll talk about that in just a minute. I find that it's a very kind of a taboo topic regardless of the diagnosis. Now obviously it's probably more prevalent in the population that has cystic fibrosis due to the coughing and having to put the pressure on the pelvic floor region. So what we want to do is try to teach everybody to do it properly in the most adequate position so that they get most effective and efficient contraction until it becomes habit for them, so that you all being individuals that have CF or have problems don't have to think about it in your future quite as much or as diligently. It's an easy topic to talk about. Hopefully, if you know somebody in your family or you're the individual having the problem, you feel comfortable enough discussing it with your physician or your physical therapist. If you're seeing somebody for even a different problem, they can help you find somebody. And if you can't find somebody that specializes, there's also the American Physical Therapy Association, APTA.org, where there is a search engine free to the public under Find a PT, where you can search for pelvic floor dysfunction or women's health to kind of find somebody that might be listed there that's close to you as well. And if that doesn't work, let me know, because I might have some other resources that can help you if you haven't gone down this road yet. The reason we want to talk about this, it's a quality of life issue. Obviously, you know that, it comes to the fact from a financial impact, which when you have any type of chronic illness, you have a financial impact of just the physicians, but also, in this situation, do you need personal undergarments? Do you need personal protection, whether it be at night, during the day, all of the above? How much do you need? That gets to be a pretty big expense for a lot of individuals. And I don't know about you all, but in my situation, as I get older, that's the last thing I have to deal with. I want to hit menopause and not have to deal with pads or poised tampons or any type of product that's going to help me not leak. So if we can find techniques for you and teach you better mannerisms, that's perfect. And I can get you those websites in just a short time as well. So like I said, we want to be able to talk to our physicians. It is not a bad thing. This is going to improve individuals' quality of life, male or female. Men are less likely to talk about it. Females, we go to the gynecologist, we go to our, yearly wellness checks. Sometimes we talk to our girlfriends, our support system. So reach out is a topic that needs to be discussed. We're getting better about it. There's still a lot that needs to happen. So I'm going to give you kind of a sorry, I saw the word low. I'm going to give you kind of a quick review of what I would do during a pelvic floor evaluation. What we would do is, obviously, like any physical therapy evaluation, we're going to look at all the medical history, comorbidities, when does happen, when is it happening, how do you do with urges, do you have to get up at night, are you using personal undergarments, what kinds of things are going on in your life, does it only happen if you cough or sneeze, is it when you're doing your clearing to get your lungs cleared out, using your vest, if you're using a vest, how do we need to implement it into your life? So we're going to look at all that as a history. We're also going to look at if there is a low back history, because low back and sacral dysfunction can cause, or lumbar and sacral dysfunction can cause nerve impairment that might also be affecting the pelvic floor. So we need to look at we are going to look at an individual's range of motion in their trunk, their hips, their knees, and see what kind of things are going on. Literally, sometimes there are physicians that have literally gotten on the floor to see what a pelvic floor is doing when you're upright. That's when gravity is pulling down, the weight of the body is pushing down. It doesn't happen a lot, but it does happen. So, sometimes that might be a component. We need to look and be creative about how we're looking at each individual's complaints and how do we help you make that better. So yeah, let's just go back to some things about like bladder retraining, goals of bladder retraining, things that are improving bladder control by changing a person's behavior. So not only is it with your coughing, your clearing mechanisms, but do you have urge problems that we need to, urge frequency or mixed incontinence where we need to address quite a few different avenues in regards to incontinence. And this is typically talking about urinary incontinence, but it's also fecal incontinence for some individuals. So you got to be able to say those words to people. We need to learn to break the cycle of urgency and frequency. Increase the amount of urine your bladder can actually hold, because a lot of us go to the bathroom what we call JICing, J-I-C, just in case. That's the acronym JIC. And probably, before, it would be optimal to do it before you work on your lung clearing mechanisms, because that's going to cause more force through the pelvic floor and thereby obviously more chance or incidence for incontinence. Excuse me, we need to correct improper voiding habits, again, going back to the JICing, and then also increase an individual's self-confidence, because there are people that don't leave their home, not just because of the illness that they may be suffering with, but also because of the incontinence concerns. They don't want to go back out and have to find a bathroom the minute they get there, or chance leaking even through undergarments. And then looking at, how's our hydration? What are we doing? And when is our bladder functioning optimally? What are we intaking? What are we outtaking? Occasionally a bladder diary, things like that. Those aren't as frequent. Might be helpful for individuals that have CF, and that when are you intaking your fluids? What are those fluids? And how much are we outputting each time? So just little things to kind of keep in the back of our mind. And again, obviously, goals of bladder retraining is financial implications and quality of life. So when we get back to the evaluation, we've screened the external side of an individual. Then what we're going to do is, with their consent, both written and I review it verbally. If they want to chaperone, I will go get even somebody that is a registrar to sit in the room so that a person feels more comfortable. And at any time an individual wants to stop that treatment, I'm going to let them stop that treatment. But during the evaluation, I need to find out how strong an individual is. Here's the reason. You can tell people to do Kegels until the cows come home. But if they're not doing it properly, activating all of the muscles surrounding the urethra and the vagina, we're not going to make as much headway as we need to be. We need to put them laying down on their back to eliminate gravity as a factor, because that is a strength issue. And that's what we would do for any other body part. We need to incorporate that for the pelvic floor just the same. Okay? So the only tools I need are linens to keep an individual properly draped, a glove, lubricant, and literally my finger. My only tool is that. Because all that I'm going to do is, again, I reconfirm when I go to test muscle strength. I'm going to use universal precautions, make sure everything's clean and good to go. And then I'm going to look briefly. I'm going to ask an individual to bear down and make sure that I do not see any prolapse externally, which can happen whether you've had a baby or not. But with all the coughing and clearing that individuals with CF need to do, you can also have what's called a cystocele or urethrocoele, so a prolapse externally that can cause some of the leakage. So what we need to do then is find out if there's a bulge. If there's not, great, let's go ahead and proceed. If there is, let's make sure we're comfortable inserting my digit and literally going from the first joint to the second joint, again with their comfort. If they have a complaint of pain or discomfort, I'm also going to palpate internally just to rule out any associated factors. And then I'm going to ask an individual to do a Kegel. My hope is that I feel an entire relatively even closure around my finger. If I do not feel an even closure compensations in the tush or the hips. I'm going to try to eliminate that, so I might have them do another. What I need to do then is find out their baseline. So I find out their strength, which is a 0 to 5 grade. 5, you're pretty much not here for incontinence. You might be here for pain. 0 means I can't feel anything. A 3 is the midway. This is where we hope everybody is at least, but everybody's different, so we have to treat every individual different. I will tell you that most individuals that come in for incontinence are somewhere between a 2 and a 3, regardless of CF being an associated diagnoses. And I need to find out at that same strength how long they can hold it. And that means a solid hold of that volitional contraction the entire time. So an individual is typically going to tell me that they feel like they can hold it and hold it and hold it. And what I feel is the letting go around my finger. So I'm going to stop them at that time. Then I'm going to give them a rest break. I do not remove my finger. I kind of tell them what we're doing. I'm going to ask them at that same strength and at that same hold time with a full rest in between, how many can you do? We're now establishing their baseline. After we've completed that and we know how much that is, I'm then going to give them a break again, not remove my finger because it's uncomfortable to go ahead and remove your finger and then kind of feel like, okay, really, you just did that again. So I'm going to keep my finger there right in the middle. I'm not pressing on anything. My hand is like in a fist like this, so there's no fingers groping this entire time. Then I'm going to ask them in a 10-second period of time, how many strength contractions can they do? On, off, on, off, on, off. I have now figured out what that is. So by doing that, that's going to allow me the decision-making, clinical decision-making of what position is best for them to start. And again, this goes for everybody, not just individuals with CF. However, we need to look at the individual CF in a different manner because we need to get you online as quick as possible with being able to contract those muscles appropriately when you're against gravity and when you're doing your clearing, your coughing, things of that nature. So we have to find out what's best. So I might have somebody start laying on their back and within a week or two progress them to coughing, sneezing, or just something as simple as sitting up statically. Because once we start moving and we start coughing, that increases that intra-abdominal pressure like you've heard before, and that increases the pressure on the lower abdominal region and the pelvic. So the rule of thumb about Kegels, well, there's a couple. First of all, don't do them while you're urinating. If you need to find your pelvic floor muscles, it's fine to do it like once to find out and stop the flow of urine. But if you do it as a rule of thumb, it causes other retention problems and possibly problems. Okay. Sorry, I'm getting old, so I apologize. The other rule of thumb is you should be able to do Kegels and not a single person knows that you are currently doing them. So how many of you guessed that I have done a lot of quick ones and I've done a lot of slow hold ones? Hopefully not a lot of you have noticed that, but that means there is no body movement at the trunk, at the hips. There's nothing going on. I'm not squeezing my legs together. My tush is not squeezing. That is the key. That's how we know we're doing a Kegel correctly. And somebody in the PT realm, possibly a physician, but they're not actually trained on manual muscle testing of the pelvic floor as a whole. That's not part of their training. So that's why you need to go to a physical therapist that is working in that arena. And they can help you assess whether you're doing it correctly. If you're not doing it correctly, there's a lot of facilitation techniques, a lot of other things that we can help incorporate into your home program. I don't see people for long periods of time for this because it's a lot of homework. Usually I see between 2 and 6 visits over a 6-month period of time. And it's when you come back, how are you doing? And let's do some progressions. Progressions are typically functional activities, changing your position, daily activities, and obviously for the CF population, we need to look at coughing and clearing mechanisms and how do we incorporate it with that. Again, the goal is that you incorporate it into everything that you do, functional movement patterns and activities of your daily life, and that you really don't have to think about it. But studies have shown that that takes a good 2 to 3 months to even really start to see that impact. So, other big component is a lot of people hold their breath when they're trying to contract their pelvic floor. That's a big no-no, and obviously we don't want to be doing that because that increases the intra-abdominal pressure at the same time. Okay, so again, and I know we're hitting that 20-minute line, so I'm gonna kind of stop there and just kind of give you the opportunity to go over the more with Georgia, and then I am happy to answer tons of questions. I literally, this is an hour-and-a-half presentation, trying to bring it down to 20 minutes. So I'm happy to answer any questions as we go down through the road.
Thank you, Beth. I appreciate that.